Welcome, ladies and gentlemen. Welcome to our members of the Hellenic Arthroscopic Association from Malta. Welcome to the members of ESCA from Greece. Welcome to all the members and all participants from all over the world. This is the third webinar of the Hellenic Arthroscopic Association, and the topic is ACL reconstruction. New trends and new techniques in ACL reconstruction. Why, when, and how. Distinguished speakers from all over Europe, well known for their experience in ACL reconstruction and with their significant published work in this subject, will expound these new techniques. And of course, they will answer our questions. From participants, the chat is open and you can pose questions to all speakers. I would like to thank ESCA for the contribution to this webinar. And now I think it's the right time to welcome here my co-moderator, Nikos Koukoulias from Thessaloniki, Greece, a well-known orthopedic surgery in the arthroscopic committee, and the doctor of the Greek national basketball team for many years, is my co-moderator. Nico, welcome.
Good afternoon, everybody. I would like to welcome our guests and participants. I'm really excited for this webinar. Today, the Hellenic Arthroscopic Society has the privilege to host 5 very experienced surgeons, pioneers in ACL research and surgery, and they're all excellent speakers. So I'm really excited for this webinar. Vasily, thank you for the invitation. I think we have some difficulties in the beginning with Robert. Is that right?
Yes, we have a technical problem, but we will overcome that. And
Okay.
Just the order.
Then we should start with the next speaker. And if I may, I would like to present the first speaker for this webinar is Mr. Michalis Iossifidis. He is the president of the Hellenic Arthroscopic Society. And he will, and his lecture is about the all-inside technique. Mr. Iossifidis, if you're ready, the screen is yours.
The powerful game-ready system provides optimal therapeutic benefits following injury or surgery. The dual-action wrap combines cryotherapy with intermittent compression. In combination, these therapeutic benefits reduce pain and swelling and help lower opioid use. To learn more about the game-ready system, visit us at gameready.com.
Hello to everyone. It's a very great honor for us to have such colleagues from Europe, and of course it's a great honor with our great audience. And as far as I know, from the registration, we have colleagues not only from Greek Arthroscopic Society, not only from our Greek colleagues, orthopedic surgeons, but from orthopedic surgeons all over the world. So it's a great night for us, and we are on our way to keep on this condition with the webinars and to do some others in the next months. So the next few minutes, I share with you the answers to why, when, and how we use the all-inside ACL reconstruction. And the outline of my presentation is, first of all, to answer why and when through the comparison of this technique with the standard ACL reconstruction techniques, to say how to describe the techniques and to go to the literature briefly and give some clues from the clinical outcomes, and finally to give some messages for all of us. So the early site technique of ACL reconstruction is defined as creating the bone socket or a half tunnel from the articular side of the tibia, rather than conventional full-length tunneling through the knee joint to the outer cortex of the tibia. And the second major point of this technique is the using of suspensory devices both in femur and tibia. And of course, these devices have the advantages of the adjustable loop cortical suspensory devices. So the surgeons, the authors who published about the all-inside technique reported or proposed some advantages of combining the all-inside technique and the suspensory graft fixation. And these advantages include the biomechanical higher graft durability, the greater preservation of leg strength, the less bone tunnel widening in further follow-up, the reduced incidence of complication, and finally, increased postoperative muscle, tendon, and bone preservation. And of course, there are some more specific advantages like the decrease of pain through the reduction of skin incision or the irritation of periosteum. And of course, this use of socket and the half tunnel proposed as to accelerate the graft maturation and prevent the enlargement due to the elimination of the dead space inside the tunnel. And this technique was designed to accommodate any graft type and was considered to be a new minimally invasive option for ACL reconstruction. However, whether the only side technique is superior to conventional full tibial tunnel techniques remains extremely controversial. And let's find out why and when. First of all, the major point is the graft choice. The all-inside ACL technique typically utilizes a quadruple, not so many types, triple, semitendinosus tendon autograft, vice the standard use of the patella tendon or the semi-T and gracilis, both tendons, hamstring tendons autografts. And of course, the technique through the closed femoral tibial sockets and using suspensory devices in both sides caused a decrease of the necessity to have very length grafts. So a single hamstring tendon maybe is enough. And if we have a length of around 26 to 28 centimeters of a whole tendon, we can get a quadruple one about 6.5 centimeters length. But this graft quite always is the diameter of the graft is equal or bigger than 9 millimeters, and always at least is 8 millimeters. And of course, there are many studies, both biomechanical and clinical studies, that report that this quadruple tendon graft can reproduce similar knee stability compared to the native ACL. And of course, we all know about the concern about the functional deficit associated with the autograft harvest. The flexion weakness is an acknowledged issue after ACL reconstruction with hamstring tendons. And there is a meta-analysis described that we have the lack of the force in greater extension after using the patella tendon and in big flexion after using the hamstrings at the 12 months follow-up. And again, however, there are many studies that reported, and including meta-analysis, that no significant differences in muscle strength between the ACL reconstruction using patella tendon, semi-T and gracilis both, or using just one hamstring. And of course, the use of the suspensory devices both in tibia and femur is the one of the specific aspects of this technique. We know that the femoral suspensory fixation is a well-established and an evidence-based option, may be dominant in soft tissue graft when we use the soft tissue in the all ACL techniques, but the suspensory fixation at the tibia is the focus of research efforts. And of course, there is the concern about the widening of tunnel. So there are many studies about the possibility using a suspensory device to enlarge the tunnel through the fluid penetration and micro movements inside the graft in the interface between the bone and the graft, and to have the well-known bungee and windshield wiper effect. On the other hand, there are other studies about the inflammatory response of the foreign bone reaction to the bioabsorbable screw, which could in turn cause a biological cause of tunnel widening inside the graft. Using the aperture fixation means to put the screw in the end of the tunnel in the joint. You increase the stiffness in the knee, but you may prevent from both bungee cord and windshield wiper effects. But there are meta-analyses compared clinical outcomes using patella tendon, intratunnel hamstring tendon fixation, or extratunnel mean suspensory hamstring fixation technique, and concluded that there is no significant difference in terms of normal laxity measurements or in graft failure rate. And we all know that using the adjustable loop is a relatively new device, and these devices offer various advantages like graft maximization in short femoral tunnels, avoidance of multiple loop sizes, avoiding over-drilling of the femoral tunnel, and do not have the empty or dead space, mostly in the femoral tunnel, or finally obviating the need to calculate the loop length in the standard using of suspensory devices. But there are many biomechanical studies reported that the adjustable loops behave less favorably in terms of lengthening than fixed loop when subjected to increased load cycling loading. So there is, on the other hand, there is no clinical studies, series of studies or meta-analysis to find differences between the using adjustable and fixed loop devices in terms of stability, knee scores of graft failure. And for this special condition of open epiphysis, it's the all epiphyseal, all inside technique seems to be the major option. Of course, it's a challenging procedure because it's time-consuming, and you have to take care about some difficulties, like to pass this graft, this thick graft through the medial portal, and to take care about the possibility the button to not unlock, unfold it in the cortex of the bones, or the breakage of suture of the advancements when you advance the suspensory device. And of course, the possibility of graft and tunnels mismatching. I put in this slide this part of the brochure from Arthrex. For a 70 millimeter graft, they propose to have a kind of 80 millimeter space to put this graft in order to avoid any mismatch. So maybe you have some 10 millimeters more than you need tunnel in the tibia. And of course, to use this retro drilling, you can easily, without hyperflexion, to do this and to get an anatomic position for femoral tunnel without hyperflexion. But again, is a special instrumentation, not always available, and of course, increase the cost. And sometimes in hard bones, maybe this retro drill have some difficulty to create the tunnels. And how we can do this operation? I put this is my term, the classical one, and the semi-all inside technique. So in both the first one, the official of James Lyubovitch, clearly 2010 he put this technique. But the other one, the kind of semi-side technique described from Silva, I use it the last 2 years in many of my cases. Graft preparation is pretty much the same in both techniques. You have to have the 26 to 28 centimeters of tendon, to fold it 4 times and to secure this 4 times construct, let's say, as we can, with extra suturing, especially in there is not a use of the tendon, and this cost in special taste very usual in all in techniques of face reconstruction to get some tension. And finally, doing all this to have, as you can see, this video, one of my cases, to get this 7 millimeters of graft length. And in the so-called, from me, classical technique, to first drill the femoral tunnel using the retro drill and this special aim guide, or to use the usual from the anterior medial portal drilling of the femoral tunnel. And after that, to use always the retro drill for the tibial tunnel. To advance, to insert the graft through the medial portal first to the femoral tunnel, and to unfold the suspensory device and secure it in the cortex of the femur. And after that, to put the other edge of the graft through the medial portal to the tibial tunnel, and to avoid any interference of the soft tissue or the possibility of contamination, you can use this passport cannula from Arthrex, or to use this special cylinder plastic device of measuring the graft diameter and as a cannula to put the graft inside. And finally, to advance the loop and use this open-like kind button in the tibial cortex. And the other, let's say, technique, the official name from the study of Silva is quadruple semitendinosus graft construct and suspensory button fixation for ACL reconstruction, and I name it semi-all-inside technique. You can do the femoral tunnel as usual from the medial portal with knee hyperflexion. You put the pin guide in the usual way in the tibia. After that, prepare soft tissue of the tibia, and you massively for 2 to 3 millimeters the cortex into weaken it. After that, using this special device, you can. So in this video we can see, and the other one, we use this special device to take out, to remove a cylinder bone plug from the tibial metaphysis, and we use it later on. And finally, we finish the tibial with usual rimming. And we pass the graft through the usual from the tibia. We secure the graft, the femur, with the adjustable loop. Finally, we secure the graft to the tail with the second suspensory adjustable device, which has to be in length bigger than the usual in order to accommodate the 9 to 10 millimeter wide tibial tunnel. And finally, after cycling the knee, to put this cylinder bone plug back using the same instrumentation, removing the handle, and as you can see, you firm the tibial tunnel and have this from a CT scan from Silva's study, you mimicking, let's say, the closed tunnel in the tibia. So in the last 2 years, many of our cases are using this procedure. We followed 31 patients for around 1.5 years. We have no pain with a full range of motion in this no giving way and no graft failure, and according to IKTC KUS and Tegner activity scales in 12 and 24 months, we have good results in this very short-term follow-up of our patients. And looking through the literature, the all insight of ACL reconstruction technique is a promising technique given the low graft failure rates reported and the short-term clinical significant outcomes for knee function, pain, stability, and patient satisfaction. However, there is a need of evidence to verify if in a long-term basis we have the same effectiveness. Of course, we have to equalize the cost to use this technique. And of course, we need additional comparative studies with larger samples to investigate if all these proposed advantages of reducing revision failure rates or improve the graft incorporation are really true in a long-term basis. And I put this table from one, I think, very good meta-analysis and systematic review of last year, 2020, and we see that just 6 studies are compared to the standard and the all-inside technique, and this systematic review and meta-analysis concluded that we have a limited follow-up period, and none of these 2 techniques are clinically superior about the functional outcome or the knee laxity. And of course, they recorded the use of a thicker graft and the less tibial watering. So, in conclusion, when we try to answer to why, because using only one hamstring may reduce possible flexion torque deficit, you get for sure a thicker graft. The using of adjustable suspensory devices eliminates the empty space in the tunnels, and of course, using this technique may this have a biologic role to better incorporation in tunnels with no devices in. And when? Maybe always, especially when the surgeon decides to in favor of soft tissue grafts, and especially maybe in patients in sports that require to have a very good knee flexion after the operation, and of course in the skeletally immature patient. And how I think both the official, the only let's say technique, and also the semi all inside technique can give all these advantages. Of course, there are disadvantages. My major concern and the literature concern is about the possibility of lengthening of the retired all these adjustable suspensory devices. It is a time-consuming operation, more than the usual. You need the special instrumentation, and of course, we need to equalize the cost. But as far as one could feel confident, and I feel confident through the evidence-based and the consensus about any topic, with the suspensory devices in both sides, with the adjustable suspensory devices and the short grafts, the answer to why is why not, and the answer to when is almost always. Thank you very much for your attention. Thank you for being with us.
Okay. Can we see Mr. Iossifidis as well? Thank you very much for our technical support. Mr. Iossifidis, thank you for this excellent review of the all-inside technique. You've described the advantages of the technique clearly. I would like to ask you, do you use this technique in cases that you would otherwise prefer a bone patella tendon graft, for example? Do you use this technique? Has this technique increased the utilization of hamstrings in your current practice?
No, actually, I am just about to use only this technique when I use hamstrings, not to replace the patella tendon bone. So I have concerns if I have to use a stronger graft and this bone-to-bone consolidation inside the tunnel. I still prefer bone patella tendon bone.
Okay.
Michael,
we're going to
another question. Are you using the technique with the insertion of the tendon via the portal or in the traditional, let's say, way?
No. As I said, what you mean in the all inside technique?
Yes, yes.
Yes. I use the Silva technique. I called it, it's not an official, but I called it semi all inside technique. It's a kind of mimicking the original all inside technique. But I think with this technique, Silva techniques, you can overcome some difficulties from the original, let's say, all inside technique and get the same results or the same advantages, let's say, of using. And the two major advantages is to use just one tendon, a thick tendon, and to feel confident with suspensory devices in both sides.
All right. So, thank you, Michael. We must inform all the participants that we have decided that we will have a discussion, a further discussion at the end of all the presentation. And now it's time for the next speaker. The next speaker comes from Poland, from Warsaw. Robert Migielski is very famous for his excellent research work in anatomy of the knee and in a new way of knee dissection. A few years ago, his research work was in the native ACL, and he has some new findings. He changed our perception about the shape of the native ACL, the so-called ribbon-like appearance in the femoral insertion, and the so-called C-shaped in the tibial insertion. In this finding, focused in these findings, he performed a new technique. So, his lecture is ACL reconstruction using a ribbon-like graft. Why, when, and how? Robert, the podium is yours. Actually, in fact, the screen is yours.
Ladies and gentlemen, my friends, thank you for, first of all, I would like to thank for the invitation and for the nice introduction. I would like to show you some short presentation about the different approach to the ACL reconstruction and the three questions, why, when, and how, I will just explain you. Why? First of all, in 2014, we published the paper in the Casta Journal about the ribbon-like appearance, which is very, very important for us, and to change the approach to the ACL reconstruction in my hands, and I do believe in the for the many doctors around the world. Before we published this paper, I did over 111 dissection in the fresh cadaveric knees. All the cadavers were from US, and there was the different race, Caucasian, Afro-American, and the Native Americans. And we did the CT scan, we did the MRI of the specimen, and then we did a dissection. This is another thing. This is the video which I got from the Charlie Brown and James Robinson. You can see on this video, this ACL looks like a ribbon. It's not a round or oval structure, but looks like a flat structure which changes direction during deflection and extension and fits to the intercondylar notch, depends on the angle of flexion. These are the pictures from our study. You can see the ACL dissected from different sides. Why the ACL is so flat and why the dissection is so clean, in my opinion? Because we removed the synovial membrane. And this is very important. If we do the dissection, we have to remove the synovial membrane. What about the femoral insertion? This is still the answer on the question why. If you look from the back, I removed the posterior capsule. You can see the ACL. I touched the ACL with the probe, and then I cut the ACL just like that. And what you can see that the ACL in the full extension absolutely is not the round structure. It's the flat structure, which has also the flat insertion area to the femur. If you look at the split at femur, this is the lateral condyle. Please note that we have this part of the ACL, which is so-called the mobile or direct insertion, direct fibers, and back to them we have the different part of the femoral insertion, which is fixed or indirect part. We measured the ACL, as I said, based on the over 111 dissections, and what we found out that the ACL is really flat. It's not thicker than 1.2 to 4.3 millimeters, and in the width is like 12 to 17.4 millimeters. It's absolutely not round, and it is not oval. This is very interesting work of Andrew Emis, Professor Andrew Emis from London Imperial London School. And you can see here, this is the femoral attachment of the ACL, and the researcher, they divided this attachment into 12 fields, and then randomly they cut different squares, getting some results. I will just share with you the results. You can see here, this is the GH. These are the fibers which are inserted on the closer to the posterior cortex. And you look at the graph, please look at the graph, then you can see that in 0, 30, 60, 90 degree, G and H, they are the most fibers that transmit the loads. If you look at this, we can say that the squares E, F, G, H, they can transmit it 82 to 90% of the resistance to tibial displacement and the femoral attachment. It means that the rest of it, the A, B, C, D, and I, J, K, L, gives us 18 to 10% all the force transmitted. Then E, F, G, H, the most loaded part of the ACL attachment to the femur. If you look at this picture, this is the EFGH. This is the most loaded part of the ACL femoral attachment. But what is very interesting, these EFGH squares or fields, they are lying on the extension of the posterior cortex in so splitted knee. Separately, we did another study. There are the radiological study. We took 30 cadaveric knees. We cut it. We separated the medial and the lateral condyle. And then we put here some marks. You can see the blue suture. The blue suture is visible on the X-ray, and the small balls. Each ball is 1 millimeter in diameters, and you can see. Then, if we put it together, these two parts of the femur, we got such picture. It means we have with the suture, we mark the border of the cartilage and the posterior border of the direct fibers. With the balls, the anterior border of the direct fibers of the ACL femoral attachment, which is exactly on extension of the posterior cortex. That's about the femoral attachment. What about the tibial insertion? We repeat the same things. We cut the ACL 2 millimeters above the tibial insertion. And then what we find out, you can see here that the ACL attachment is surrounding the anterior root of the lateral meniscus. It's not in the lateral meniscus. It's surrounding the lateral meniscus anterior root. In our study, we could divide the different shapes of the tibial attachment to 3 groups. The 67% that was the C shape, so-called the C shaped. The J shape is like the flattened, just a little bit C is 24%, and so-called double C is only 9%. We did another study with the Imperial College London with Professor Amis. There was I would say the blinded study, because Professor Amis did the biomechanical study and separately blinded, we did the anatomical study. He divided the tibial insertion on 9 fields, and then randomly, like before in the femur, they cut the different fibers, checking which part of the ACL attachment to the tibia is the most loaded part. And what they found out, you can see here this different graph as the A zone or B zone. A zone is mostly like the C, and on the second picture you can see the 1, 2, 3, 4, and LG is the lateral gutter zones. What they found out, you can see here, that if you look at this, the mechanical result matched with the C-shaped anterior medial attachment of the dense collagen fibers of the ACL. It means the part A on the left picture and the part 1, 2 on the right picture is transmitting the most load, the most forces to the tibia. You can see here this one, and you can see the A or 1, 2 is the most loaded part of the tibial attachment. Another thing is that if we can calculate, if you put your graft in the flat slot, you get 30% more the surface, the contact surface between the graft, the soft tissue graft and the bone ingrow to the graft to the bone. The graft ingrow to the bone is much better than in the round tunnel. And lastly, answering on the why, because there is another study published 2 years ago that if we have if we have the flat tunnel, we can expect the better ingrowing, the better healing, and the better fixation of the graft to the bone, and the faster. What does it mean? The anatomy should allow us to design the operative technique, and the operative technique should restore the anatomy as much as possible. And now is this next question, is the second question. How? I will just show you how. Short video, please look at the ACL. You can see this is combined with the Chopin music. I'm from Poland, that's why Chopin. And you can see that's how the ACL changed the direction, changed the position in the knee during the flexion and extension. What about the femoral insertion? If you want to make the ideal femoral insertion, what we should get? First of all, we should divide the femoral insertion to 2 zones, direct and indirect. Direct is the most loaded part of the ACL. This is what we can confirm. Then the graft cannot be too thick. If we have the very thick graft, we have some conflict with the intercondylar notch. We have to compromise some things. It means it should be also in the extension of the posterior cortex. These are the the background. And now what we can do, we have this. We have the soft tissue graft. We can put it here, and you can see the very small, short 1 minute video. You can see this is the remnant of the ACL. I put my aimer. Now just try to see. I put my aimer just the back, close to the posterior cortex. It takes 1 minute. The video, not the surgery, of course. Then we drill the first K-wire. and then we remove the first aimer, and now we can slide down the special aimer for the slot. It means this is the special aimer for producing the slot in the femur. And then we put two another K-wires, you will see now. The central one, which is going completely through the bone, and we use the central wire just to pull in the graft into the joint. And then we have the third one, which is the close to the camera. And we remove the aimer, and we have the three different K-wires. And now we can do the drills. 4.5 millimeter drill, 3 times the central through the bone, and we measure the length of the tunnel, and then we can just, using the special dilatator, we can make the slot in the femur. And you will see that this is the slot. You can see here, this is finally on the extension of the posterior cortex. This is the effect of the making the slot, and this is the original remnant. Tibial attachment is very similar. We have the tibial attachment, which is surrounding of the anterior root of the lateral meniscus. This is the tibial attachment. We know from the biomechanical study that the C shape is transmitting the most loaded fibers of the ACL tibial attachment. And what we can do with the very special technique, very similar to the femoral one, we clean up. In this case, what you see on the left side, I put my camera from the lateral side and the scope from the camera from the medial side and scope from the lateral side. Then we use the special aimer, which we put on the remnant from the top. We put the aimer from the remnant on the remnant from the top. We put the first K-wire, which is the treated K-wire, and then two 4.5 drills. We remove the drills, and we drill the central tunnel is also the 4.5. We can clean up the tunnel, and you will see the tunnel should be round, which is the slot. And now you can see how it looks like. It's a really C shape. It's surrounding the anterior root of the lateral meniscus. And then we dilatate the tibial tunnel, getting the nice smooth tunnel in the tibia. And as you can see on the pictures on the right hand side, this is very similar. This is the effect of this approach. Well, then the soft tissue Mars technique, what we have to do, we have to restore the two tunnels, and then what we can use for the graft. I use two kinds of grafts. I use the quad tendon graft, soft tissue only, or flattened semitendinosus, which can be folded 3 or 4 times, and we can get also the flat graft. You can see this is the semitendinosus, which is flattened, and we can get a really nice graft which fit perfectly to the tibia and femur. And you can see the result. There was the quad tendon. You can see how it looks like. It really fits even to the very narrow intercondylar notch. In the normal case, normally it should be probably done the notch plasty, but I don't do that. I just try to fit the graft to the space between the PCL and the lateral condyle. What is the post-op results? Look at this. We check if the femoral tunnel could be enlarged. And 3 months after the surgery, we checked on all our patients. It's over 150 patients are right now. We can see there is no tibial or femoral tunnel widening. You can see that there's a 3 months post-op. And this is the MRI. We ask our patients to do the MRI, usually 3 Tesla, 3 months, 6 months, 9 months, and 1 year after the surgery. And then 1.5 years and 2 years after the surgery. You can see now this is the 3 month, this is the 6 month, this is 9 months, and this is 1 year after the surgery. It looks really very good, and honestly, if we ask the patients, they feel very normal. The last thing is just I would like to say to whom we should address this surgery. In my opinion, to everyone active patients in the first surgery. And what is very interesting, this flat technique allowed us to compromise in the revision surgery with the round tunnels. It allowed really nice and very easy reconstruction using the flat technique. This is what I use for which patient I use. Well, and finishing my talk with Gaudi, he said that nothing is invented, for it's written its nature first. Originally consists of returning to the origin. Thank you so much. Thank you for the attention.
Excellent presentation, Robert. Excellent work, excellent research work and anatomic dissection. We can see Robert here. Just for a short comment, I think for someone who is used the medial portal for ACL reconstruction, the learning curve for this technique is not so difficult, let's say. We just need a new way for preparation of the graft, a special instrument. Am I right?
If someone is quite good in skills and is familiar with the instrument, there is not so very special technique. It's maybe just a little bit time consuming because it takes just a little bit longer. Because instead of one tunnel, we have to drill 3 tunnels in the femur. Then we need to dilate it. Same with the tibia. Instead of one tunnel, we make 3. But the result and the effect is really very good. I would just always just to propose to try that first, maybe on the cadavers, to see that's really very intuitive, like the Mac computer. It's very intuitive. You can do it, you can feel it, and it really works.
Okay, I think we have many. Nikos, yes.
I think we're running late. It's very interesting, and I'm sure we'll have many questions on this technique later on. But Vasily, we have to go on, and please introduce us the next speaker.
The next speaker comes from Luxembourg. He's a well-known speaker, he's a very famous surgeon. He was the president of ESCA, our big family in the past, and he's a member or founder of many groups and consensus groups and study groups. You may wonder why in this webinar with ACL reconstruction we are talking about meniscus rub lesions. These lesions, in my opinion, very often are overlooked. We don't see them, we don't treat them appropriately, and the final result is a new operation. So, posterior portal or portals for addressing a meniscal rub lesions. Why, when, and how? Professor Seil, we are looking forward to attend your lecture. The screen is yours.
Good evening, ladies and gentlemen. It's a pleasure to be here, and I would like to thank the Greek Arthroscopy Association for this nice invitation. Yes, so as our moderator has already mentioned, why are these lesions important? First of all, we have to look again into the anatomy, and this has nicely been worked up over the last years by some American groups, also by some European groups, with also around Bertrand, who is talking a little later now. And actually, what is important here is that we look into this anatomy again, and what we repair is a complex structure which is made of a meniscocapsular ligament, a meniscotibial ligament, and so it's very important to differentiate these also from, for instance, from the root lesions, and that's something where I see that there is sometimes a confusion done in people who are not so familiar with the meniscal ramp. And if you look at this slide again from above, at this anatomic picture, you see that the meniscus ramp on the left is this gray area behind the posterior horn of the medial meniscus. Recently, these lesions have been introduced into the classification of traumatic meniscus injuries, following the ASCA consensus of this type of lesions. And that's the first time actually that they are taken in the international classification. So it's important to have them on your own map. And here you see it from behind. That's really this meniscotibial attachment you see here, and it's a big zone spreading on the medial, on the central side, from the PCL insertion to the medial side to the insertion of the medial collateral ligament, and as well as other attachments. Now we go through, again, a sagittal section. That's what I published some years ago, where you see again the meniscotibial ligament and then the meniscocapsular ligament with a synovial membrane overlaying it. Now, how to diagnose these lesions? Can you diagnose them preoperatively? Clinically, I think it's hardly possible. What about MRI? Well, direct MRI has a sensitivity in the best studies of 70%. So this means that you may diagnose it in 3 patients out of 4. At least the sensitivity is lower in this study than for usual meniscal body tears. So it's not that great, and you need also to have good radiologists who are really aware of this type of lesions. Something which is useful and which can help us identifying these lesions preoperatively is the bone bruise pattern. And you see here Giuseppe Filardo has differentiated in the medial bone bruise pattern, the lateral bone bruise pattern, and both the medial and lateral bone bruise pattern. And we published recently that depending on the type of bone bruise pattern, especially if you have it on the medial tibial plateau, on the medial side, you have an odds ratio which is 6 times higher in comparison to a group of patients who didn't have ramp lesions for this type of lesions. So look at the bone marrow edema, and you can get prepared to find the lesions. Now, how do they occur? We still are not 100% sure how this occurs, but if you look at these very nice videos of these tibiofemoral subluxations, up to 25 millimeters anterior tibial translation at the moment of ACL injury in the medial compartment, well, they may lead to these disruptions of the posterior tissue of the meniscotibial attachments. So again, look at these videos. These are really dislocations or subluxations of the knee, which are really important to detect. And these are not minor ACL injuries. These are really big ACL injuries. Their prevalence has been indicated in the literature, I would say, between 15 and 25% from studies, early studies from Steve Boland more than 10 years ago, to series up to now. And it has also been shown in children with a prevalence of 23%. Now, what is the relation between ramp lesions and other ACL-associated meniscus lesions? Well, in a paper we just published in the ASCA journal, we found that the ramp lesions are twice as frequent as the lesions of the medial meniscus body in primary ACL reconstructions. So this is not a rare lesion, it's a lesion which is frequently there and which is frequently overlooked. Now, if you want to make a thorough diagnosis, you need to go and inspect the posterior part of the knee, the posterior compartment. And you can do this with an intercondylar view. Usually you'd use a 30-degree arthroscope, and you see here on the left, right, you see a normal ramp. But in many of those patients, actually, you see this. On the left, like what we call an empty wall sign, you see that the posterior horn is really standing empty, reaching out into the posterior compartment, and you see the ligaments belonging to it, which hang down like a curtain from the wall. On the right side, you see this big crater lesion. These are all lesions which are actually important to repair. And here you see how you do it. So if you go in with your scope through the intercondylar view, and then you palpate from posteromedially with a needle in order to palpate the region, and especially important also the regions which you don't see, because with a 30-degree scope you don't see around the corner. And you can palpate the ramp, and if you have the feeling that there may be something wrong, you need to do a posteromedial viewing portal, and you can do that by using a Wissinger rod and have a direct posterior visualization, which is absolutely the best way to diagnose these lesions. And here you see on the right side actually a normal ramp, and you see how similar this is to a glenohumeral joint, to a shoulder joint actually, but it is not. And so this is a really nice posteromedial view of this ramp. This is an intact case, and now we go over to an injury actually. And you can recognize here that the ramp lesion is extending far from the PCL zone to the medial zone, and this is over 3 centimeter lesion with a distension of more than 1 centimeter in width. And this looks like a Bankert-like lesion, and that has been described in the literature previously. Here again, you see 2 pathologic cases which are more of chronic nature through a posteromedial viewing portal. And here you see 2 videos, and this shows you why it is important actually to repair these lesions, because if you bring the knee into extension, you see that there is actually a gapping which either appears or which either remains, a gapping between this posterior ramp tissue and the posterior horn of the medial meniscus. So if you imagine that you bring in a fixation device from anterior, which you do with the knee in extension in most of the cases, you can easily imagine that these fixation devices do not grab the posterior capsular tissue, and that you fix it simply in a vacuum zone. So that's basically important. Now another question, should they be repaired, and other arguments, is that actually we found in previous studies that these lesions are associated with high energy trauma, and this is similar to the videos you saw just previously, and we found also that these lesions are associated with a high degree pivot shift. So again, you find these lesions in what we call more complex ACL injuries, and not in or rarely in minor traumatic injuries. Now the question, how should they be repaired? Again here, as Robert said before, for the ACL, we need anatomic repairs. After all, that's what shoulder surgeons are doing on a daily basis when they do shoulder reconstructions. Why shouldn't we do the same in the knee? And so you see that this is on the left the image before repair, and on the right after repair. Again, it looks pretty much like a Bankert reconstruction in the shoulder. But this is an advanced technique. This is nothing for beginners. So in order to do this, we use usually some shoulder instruments like these curved hooks, as you see on the right. And if you do this, you need to calculate 15 to 20 minutes OR time. You need to decide which portal placement you do. So either a 1 versus 2 portal strategy. I will explain this a little later, what this means. You need to identify the tissues to repair. Then you need to debride the tissues for all other repairs, and you need to reposition it. And then finally you do your suture repair. And for this, again, we use these shoulder instruments. You need to be familiar with arthroscopic knot tying, And for the repair, we use absorbable sutures here, like a PDS-0 suture. I mentioned the one or two portal strategy. If you use a one portal strategy, which then you would take the A portal here on the slide on the right as a working portal, you would go in through the intercondylar notch and look posteriorly and repair through the A portal. If you use a two portal strategies, this means that you do all the work from behind, and that's basically my preferred technique right now. You use the portal A, which is pretty much proximal and anterior as a viewing portal, and then the B portal as a working portal, and this is the one where you do your repairs. Now, it's important when you repair that you put the tissue back to where it has been avulsed. And you see here, this was in a 14-year-old boy, and this, again, you need to put the capsule back to where it belonged, actually. That's very important. Now, how do you do it? Here you see an old video where I went through an intercondylar notch and then through the A portal, actually, where I did the repair with this shoulder instrument, which is curved like 45 to 60 degrees. This is a single-use instrument, and then you do your your repairs. This was before we used actually absorbable sutures, but that's something we do right now. And here you see some pictures of some of these results. Again, they look like bankhead repairs, and actually it's a safe procedure. Actually, you need to take care, of course, of the saphenous structures. You can avoid them by doing some transillumination if you apply your portal. These lesions have actually a very good healing potential. This has been shown already in the 1980s when these lesions were known at that time and where they were repaired in an open fashion. So now we don't have, I would say, extremely reliable and results in big numbers, but the impression we have that we see less secondary meniscus lesions. You all were familiar with secondary bucket handle tears which were occurring after your ACL reconstructions. This is something we see very rarely nowadays. Now we need to show in the future if this will improve ACL reconstruction outcome. And again, I would say that these lesions occur in the worst ACL lesions we see. So these are not simple lesions, but really big traumas, as I mentioned previously. So in summary, these are complex, the ramp lesions occur in complex knee injuries. We see that, or currently we suppose that they are occurring through this big trauma with these medial subluxations I showed you in the video before. Their prevalence is, I would say, around 20%, sometimes a little bit more. It depends a little bit on the patients you have. They are associated with a high degree pivot shift. Again, if you do your examination under anesthesia before operation and you have a high degree grade 3 pivot shift, then you need to strongly suspect the presence of a ramp lesion or lateral root lesion. So one of those rare meniscus lesions which we have been acquainted to in the last years only. Repair these lesions, especially if they are unstable, as in the videos that I showed you, or in these big holes pictures I showed you. This is really important. Repair is technically demanding, so you need to train on it. You need to train on cadavers before, and need to get familiar with these instruments, especially with the shoulder instruments. Now, currently in my hands and in the hands of those people who repair them, we have good outcome. But again, we need to show in the future that our ACL reconstructions will be better, but I think there is absolutely no doubt that they will be, because we do an anatomic reconstruction of all the injured structures. This should be the goal of our procedures. So I would like to thank you for your attention, and I'm ready to take some of your questions. Thank you.
Romain, excellent presentation, excellent work, difficult work, and there are many questions from the audience. We have more than 200 participants. Some of them are you answer them during your lecture. A short comment. Is it the time to think about a new era in ACL reconstruction? Many years ago, when I was resident, it was a two portals operation. Now I think it's more than two portals in ACL reconstruction. What do you believe?
Absolutely. I mean, that's it's mandatory that we do excellent meniscus repair if you do our ACL reconstructions. And if you want to do good meniscus repair, you need to have more portals. And I mean, these are just small stitches in the skin, and you hardly see them anymore later on. So why shouldn't you do it? Because the main reason is to reach the injured structures very well with your instruments, and that you don't scratch the cartilage. These are the basics I was taught during arthroscopy, so there's no reason to do just two portals.
I have a short question as well, if I may. Okay, that's a short question since I began. What is the future of the knee with an untreated rub lesion? Shall we expect stability issues, pain symptoms? What's your view?
Well, I think that the ramp needs to be seen as a really stabilizing block. It's part of the complex of the posterior horn of the medial meniscus. And we all know that this is the most important secondary stabilizer after the ACL is gone. And so we know from some biomechanical studies, which I did not mention in my lecture, that actually the ramp lesions have a biomechanical effect. And so probably the knee will kind of decompensate over time with maybe a secondary ACL and a secondary meniscus lesion. So the meniscus get lost somehow. And then we know that there is a strong relation between the posterior horn of the medial meniscus and the ACL graft. So we know that if the medial meniscus is gone, we have a higher graft failure rate. So I think it's kind of the cornerstone of the knee after the ACL, this portion.
Okay, thank you. Now we'll move to the next speaker. The next speaker is coming from Greece, is Professor Michalis Hades. Among other achievements, he is the ESCA General Secretary. Mr. Hades, the screen is yours.
Good evening, everybody. I would like to thank the organizers for the kind invitation and to congratulate the Greek Arthroscopic Society for this initiative. So my topic is the role of extra-articular tenodesis in ACL reconstruction, when and how. These are my disclosures, but nothing to do with this presentation. So the aim of anterior cruciate ligament reconstruction is not just to control the anterior stability, but also to control the anterolateral rotatory movement as a whole, as you can see from a normal ACL. It is known that the tibial internal rotation is increased in the ACL deficient. That's why we have to address also the rotational component and not just the anterior translation. After the ACL rupture, the center of rotation it changes and it's moved more medially, and that's why we have an increased lateral compartment mobility and the pivot shift test, of course. Probably the reason for this anterolateral injury is not just the ACL injury, but injury to the anterolateral structures as well, as it has been reported by many authors. What is actually the knee anterolateral complex? The group of Bertrand Sonner Ricotet did a very good work, and they defined the anterolateral complex that it consists of 3 layers. The first layer is the superficial iliotibial band and the iliopatellar band. The second layer is the deep capsulo-osseous layer of the iliotibial band. And finally, the third layer consists mainly of the anterolateral ligament and the adjacent capsule. Of course, we rediscovered in the last years the anterolateral ligament of Belgium surgeons report that 10 years ago, but this is not something new. And they reported that they found the anterolateral ligament in 97% of their cadaver specimens. And we did also have a study in our Unity anatomy lab, and we really found that the anterolateral ligament is a distinct structure, and as you can see from the videos, it really controls the tibial rotation. It's not just a thickening of the lateral capsule, but it's a distinct structure. The question is how much contributes to the rotational stability, if this is the important structure, or if the iliotibial band is the important structure to control rotational stability. So it's similar to the question, what comes first, the egg or the chicken? The group from College London with Andrew Ames and Adi Williams reported that the main stabilizer is the iliotibial band, and the anterolateral ligament contributes much less in comparison to the iliotibial band. So this is their conclusion, that the iliotibial band is the most important structure for the restraint of anterolateral rotator instability. And for those who are more interested in the anterolateral aspect of the knee, I recommend this special theme issue of the Kesta Journal, which has a lot of papers around the topic. However, there are also many other papers which reports that there is no difference between the contribution of the anterolateral ligament and the iliotibial band on the rotational stability of the knee. Don't forget that except the soft tissue structures we may have also some bony anatomy and osseous lesions in the lateral part of the knee, and the role of the lateral condyle impaction may play a significant role, especially in cases like that when you have significant depression fracture, and this could be equivalent to a Hill-Sachs lesion, and we know that this contributes significantly to the anterolateral instability. Some patients have an increased lateral tibial slope, and we pay a lot of attention in the last 10 years on the increased lateral tibial slope and the relationship with this bony, let's say, abnormality and the increased instability and the increased pivot shift test. So because of all these things, we probably have some clinical problems after ACL reconstruction, like a 15 to 20% of remaining instability after our surgery, a high retear rates for some categories of patients, revision cases with high-grade laxities, and of course the return to sports is not possible in many athletes, probably because all these things have not been addressed well in our first surgery. That's why the concept of iliotibial band tenodesis comes again into the game. This was described many years ago by Marcel Lemaire from Paris, and actually in the original description, the Lemaire technique was, as you can see, she took a part of the iliotibial band, and then the graft was passed deep to the lateral collateral ligament, and then fixed with sutures to the iliotibial band with an knee flexed at 30 degrees of flexion and in external rotation. After that, a lot of other extra-articular tenodesis techniques have been developed, the Mackintosh, the Zarians and Rowe, a combination of bone patellar tendon bone and the Lemaire technique. And as you can see, many of them were in place in the 70s and 80s. How to do it? It's not a difficult procedure. It's actually a very straightforward procedure. You have to do a lateral incision and to take a strip of the iliotibial band 10 millimeters and 7 to 8 centimeters long. And you, of course, leave it attached to the Gerdes tubercle. And then you have to identify the LCL, the lateral collateral ligament, pass the graft under the LCL, as you can see here. This will give you a pulley effect, and the graft gets in tension when you have the knee in extension. And in addition, you have low constraint and no over constraint on the lateral compartment. So the next question is where to fix your graft in the femoral part. There have been a lot of biomechanical studies regarding the fixation point in the femur, but probably the best lateral extra-articular tenodesis insertion point is 10 millimeters proximal and 5 millimeters posterior to the femur of the fibular collateral ligament. And then a good trick is to orient your K-wire a little bit in an anterior direction in order to avoid the ACL femoral tunnel. Then we come to the issue of fixation. You can use a screw, an anchor, a staple. I prefer to use a screw in skeletally mature patient, and to do this, I put my scope in the knee and viewing arthroscopically while I put my K-wire to create the lateral tenodesis tunnel. And if I see that there is no collision, I proceed with the drilling and then fix my graft with the knee at 30 degrees of flexion and neutral rotation. A trick for the children and skeletally immature patients is to put your graft under the physis, and in this case, in order to avoid damage to the physis, it's better to use a suture anchor and to put your graft and tie it with the sutures of the anchor. So the indications for that, we have a lot of indications. A high-grade pivot shift is a good indication, a high recurvatum, increased tibial slope, young patients, because we know that this group of patients have a high retear rate, revision cases, high demand athletes, and relatively indications are chronic ACL tear, meniscal loss or meniscal repair, and a second fracture. Of course, there are some unsolved questions. If this additional surgery really offers a good result to our patients, if there is an over-constraint of the lateral compartment, and this probably in the future will lead to osteoarthritis of the lateral compartment, etc. So let's see some clinical work. This is a study with a 19-year follow-up, a very good study with a long-term follow-up. And as you can see, they included 121 patients, and the tibiofemoral osteoarthritis in the lateral compartment was significantly more frequent in the lateral tenodesis group, 60%, as compared to the isolated bone patellar tendon group, 22%. Of course, the graft failure was significantly less in the tenodesis group, 13% versus almost 29% in the bone patellar tendon group. However, there are studies like this systematic review from Brian David, who reports that the rate of osteoarthritis does not increase in addition to extra-articular tenodesis, and the most important factor is a meniscectomy and not the lateral tenodesis. From a clinical point of view, many studies reported that we have better clinical results, higher return to sports activity, less ruptures, and probably the best evidence, the best study is this one, which is a randomized clinical multi-center trial. And the results report that there was a 12% re-rupture rate without lateral tenodesis and 4% re-rupture rate with lateral tenodesis. And this was significantly different between the groups. So this is a very good proof that the lateral tenodesis works, at least in terms of stability and re-rupture rate. So in conclusion, we could say that this is a new era in ACL reconstruction. According to clinical studies, we have a better control of anterolateral rotation, better clinical results in terms of stability, return to sports. However, there is a risk of overtreatment. I know many surgeons that prefer to do it in many patients. I would say that in my hands, this almost 40–50% of my patients. And of course, the long-term osteoarthritis is always a concern in these patients. So I would like to thank everybody for the attention. And don't forget, our ESCA Virtual Congress is closed. And please go to register for this big scientific event. You can expect more than 450 speakers, more than 150 top-class sessions, and you can do all this from the comfort of your own home. I thank you for your attention.
Thank you, Mr. Hades. As expected, Mr. Hades is here with us. He will come. Here you are. As expected, your presentation was clear and comprehensive. Let me ask you, if I may, do you ever decide intraoperatively whether you will perform a lateral tenodesis or not? Maybe based on the status of the menisci or the rotational stability of the knee after you have completed your ACL reconstruction?
Actually, this is a pre-op decision in the vast majority of cases. Maybe an intraoperative decision would be if I have a graft which is not sufficient, a thin graft, 7.5 millimeter, for example, graft, then it's a good tactic to add the lateral tenodesis to make it more stable. This is probably the only intraoperative, let's say, decision, if you have a graft that it's not sufficient.
Thank you very much. Vasily, please guide us to the next and last presentation.
Thank you, Michael. And now the next presentation, the last presentation, the last speaker, but not least, is comes from Lyon, from France, from FIFA Medical Center of Excellence. Bernard Sonnery-Coté is very famous. He's a member and a founder of many study groups and many consensus groups. And in the last few years, I cannot measure how many publications he has about the anterolateral ligament and the anterolateral structure. So, his lecture, ACL and AL reconstruction. Why, when, and how? The screen is yours, Bernard.
Good evening. It's a great pleasure for me. The previous presentation was really fantastic. So many congratulations for the Greek Arthroscopic Society. Thank you very much, Michael, for your lectures on Lemaire. You will see that I'm totally agree. But let me present the lateral extra-articulaire 2.0. This is my disclosure. I'm delighted to start my lectures on anterolateral ligament by this very nice editorial from Michael Rossi in Arthroscopy Journal. The story is not anymore if augmentation should be considered, but one, and maybe more important, how to augment. In fact, due to the development of the arthroscopic ACL reconstruction, I would say that all of us forgot to look outside the box. But when you go back to the past, for example, this two fantastic book by Werner Müller in 1982 and by Jack Houston in 1993, you will see that the description of the concomitant anterolateral structures is very well described, but also the posteromedial associated lesion with an ACL. But in fact, for the last 30 years, all the surgeons talk on the same subject, which is ACL fixation, the type of graft, BTB, hamstring, or quad tendon. But I would say that if the problem is in these two items, it would be solved a long time ago. In fact, when you see this kind of ACL injury, is a very complex mechanism with an association of translation and rotation. If we summarize, an ACL injury is very often an association of an anterior tibial translation, which explain the ACL ruptures, and in around 10% of the case, lateral root lesion. But due to this internal rotation, you have concomitant lesion of the anterolateral structures. But with this automatic contraction of the semimembranous due to the excessive anterior tibial translation, you have also concomitant posteromedial injury, which explain probably the ramp lesion very well described by Romain Seil. We published this study many years ago where we analyzed with a 3D MRI the acute ACL ruptures, and we found a concomitant anterolateral lesion in 87% of the case. We have a paper accepted in the American Journal where we show that we have less than 30% healing rate on MRI control to this anterolateral ligament. Moreover, this fantastic study done by a team of Ferretti, where they used to open acutely the anterolateral side of all injured knee, they found a concomitant lesion of the anterolateral structure of the knee in 90% of the case. 90%. So why there is still this important controversy around the existence or the function of this anterolateral ligament? In fact, everything is due to the dissection protocol, because there is a few key points very important, which mean the first key point is to reflect the IT band proximally to distally and not anteriorly to posteriorly. Then you have to resect the biceps in order to find the lateral collateral ligament, and you must find the ALL from the tibia to the femur. It is these fine structures who overlap the lateral collateral ligament, which means that there is no link with the capsule, is superficial to the LCL. And I get this fantastic invitation by people at the Imperial College of London, where Christoph Kittel, we published a lot of papers saying that the ILL has no function, was not able to find the ILL. In the same cadaver, I apply my protocol, I resect the biceps, I come from the tibia to the femur, and look, I found this fantastic big anterolateral ligament, superficial to the LCL, tight in extension, slight inflection. And you can imagine the importance of these structures in the rotational control of the knee. We also apply this same protocol, C-section protocol on this fresh fetus. Look at the size of my finger. I reflect the IT band proximally to distally. I resect the biceps in order to find the fibula head and then the LCL. So I went gradually from the fibula head to the femur. And look, I found this structure, which is superficial to the LCL. We also analyze in histology. It's clearly it's a ligament. It's superficial to the LCL. It overlaps the lateral collateral ligament, and the tibial insertion is between the Gerdy tubercle and the fibula head, which is the location of the second fractures. In fact, why we have to talking on the anterolateral structure of the knee? Because our clinical outcomes in 2021 are just unacceptable. There is no other example in orthopedic surgery where surgeons accept this disaster, which is a graft rupture rate around 20% in high-risk population, a reoperation rate around 90 to 26%, and a return to pre-injury level only between 50 to 65%. So our clinical results are completely disastrous. We know from the lateral extraarticular tenodesis, mainly the Lemaire published in the past, that the graft rupture rate is low with the extraarticular reconstruction. And we also know that probably is a good question from Michael. Is there a risk of osteoarthritis? We mostly think that the presence of a meniscal injury is the more important predictive factor for an osteoarthritis. In France, we grew up with the Lemaire in the 70s, but we know perfectly well the limit, the risk of overconstraint, and the rate of complication. So we move from this Lemaire to this anatomical anterolateral reconstruction based on the dissection published by Stephen Claes with a broad tibial insertion. You can do it independently, whatever the graft you use. You add this anterolateral ligament with a triangular shape. We do it percutaneously, and it's very important because we preserve the IT band, because we consider that the IT band is very important for the rotational control of the knee. This is this combined ACL ILL, which our preferred technique we use routinely. We draw the landmark on the skin, and we join these two tibial tunnel with this just specific jig. The most important, and Michael described it very well, you have to be proximal and posterior to the lateral epicondyle. So we do the femoral ACL tunnel with this in this location. So it means that we have only one tunnel in the femur. For the tibia, there is nothing special. We always keep the hamstring attached to the tibia for better healing and better fixation. And we use the triple summity for the ACL and the gracilis for the ILL. We fix the ACL graft with an interference screw in the tibia, another one in the femur at 30-degree of flexion, and we do this ILL reconstruction under the IT band, percutaneous incision. With the gracilis, we go from the femur to the tibia, and then with a triangular shape from the tibia to the femur, back to the tibia to the femur under the IT band as well. And we fix it in full extension because we are sure to be in neutral rotation, which is a very important part of the procedure. We just secure with the suture traction from the ACL. So it means that we are doing this ILL without any additional implant. You can do it isolated. It means that you do your own ACL. It's exactly the same procedure on the tibial side. There is nothing special, just that we fixed this ILL reconstruction on the femur with a swivel lock. You pass under the IT band from the tibia to the femur and then back to the femur, and you just secure with the suture traction in full extension. But the most important is all our discussion is our clinical outcomes. We published this series in 2017 based on 500 risky patients where we propose 3 types of reconstruction: isolated BTB, isolated hamstring, or combined ACL and an ILL. And we demonstrate in this paper that we have 3-fold less graft rupture rate in the group of the ILL reconstruction, including compared to the isolated BTB. We were also worried with the risk of complication that we observed and we had in the past with the Lemaire. So we published this series of more than 500 patients where we analyze the reoperation rate and the specific complication to the ILL reconstruction. We found 13% of reoperation, but only less than 1% of specific complication due to the ILL reconstruction, less than 1%. Then we also demonstrate that when you have a ramp lesion, very well described by Romain once again, when you repair this ramp lesion with the posteromedial portal, adding an ILL reduce the rate of secondary meniscectomy by a rate of 50%. So we have less than 5% secondary medial meniscectomy when we perform the repair of this ramp lesion through a posteromedial portal with an ILL reconstruction. We also demonstrate that this technique is efficient in athletes. With a mean follow-up of 4 years, we have a low graft rupture rate, 5%. And interestingly, we have 2% in male athlete, but 13% in female athlete. So for female athlete, we consider that it's probably not sufficient and not efficient. So I'm going back to the Lemaire for the female athlete, professional female athlete. We just have this paper accepted 2 days ago, where we perform a match study based on 7 different criteria with a mean follow-up of almost 10 years. We find no difference in terms of clinical outcomes with 2 groups of patients, 82 patients with combined ACL and ILL, and 82 isolated ACL reconstruction, including 1/3 BTB and 2/3 hamstring graft. We did not observe any big difference in the Q score, but in terms of graft rupture rate in the isolated ACL group, with a mean almost 9 years follow-up, we found 17% failure rate for 3.5% in the ILL group. So it means that the odds ratio is over 5. So it means that you have 5 times less graft rupture rate with when you perform an ILL compared to an isolated ACL reconstruction. We also analyze the reoperation rate. It's 30% in the isolated group, which is a disaster, and 15% in the ILL group, which is also difficult to accept. We also start a prospective randomized study in 2016, including almost 600 patients. We already finished a study, but we have 2 more years for a longer follow-up. We already published this preliminary result showing a less graft rupture rate in the ILL group compared to the BTB, and less complication and better clinical outcomes. So it means that this combined ACL and ILL reconstruction provide better clinical outcomes than the gold standard BTB reconstruction. Hopefully, these very nice clinical outcomes with a low complication rate, but better clinical outcome, including less graft rupture rate, has been already published in many countries, Brazil, Korea, and Japan. Let me show the difference between the Lemaire and the ILL reconstruction. It's mostly, the size of the scare, and we consider that you can do an anatomic extraarticular reconstruction without using the IT band, which is a very important structure to preserve if possible. Like Michael, we still have some indication for the Lemaire, but you see, I mean, we extend massively our indication for ILL because we now propose the ILL reconstruction in all patients with high risk of graft rupture, which is around 80% of our population. We also keep some indication for the modified Lemaire. I would say that when it's really a loose knee for ACL revision, chronic ACL tears, high demand and female pro athlete, but also in pediatric population. So we still use Lemaire, which is better than nothing, definitively. And one very recurrent question is when to perform a lateral extraarticular tenodesis. It's a very good question. I just analyzed my own series of patients, more than 200 patients, where I personally perform the primary ACL, but also the revision. During the primary ACL reconstruction, I found 7% of chondral lesion and 45% of meniscal tears. In the same population, when I revise them, I have an increase, a significant increase rate of chondral lesion and a significant increase rate of meniscal tears. So believe me, if you reserve the lateral extraarticular tenodesis for your revision, it's already too late. You have to do it in your primary risky patient. In conclusion, our clinical outcomes are still not acceptable in 2021. Believe me, we have to analyze honestly our clinical outcomes, and you will be very depressed like me. The lateral extraarticular tenodesis, whatever the technique, is mandatory in high-risk population to decrease the graft rupture rate. The clinical effectiveness of ILL is now proven by multiple groups and our different studies. The safety profile and the reoperation rate are better with ILL compared to modified Lemaire. And I want you to be very happy that for me, definitively the overconstraint is a biomechanical cadaveric wart. It's not true in our real patient. In the same series of patients with 10 years follow-up, we are doing a comparative X-ray, and we do not find any single case of osteoarthritis due to the extraarticular reconstruction. Thank you for your attention.
Fantastic presentation, Bernard. Thank you for this presentation and for the video demonstration. Can we have Bernard in our company? Because we want to have a short comment about the learning curve for this technique. How difficult about the learning curve for this technique, how difficult it is to start performing an ALL reconstruction?
I mean, it's difficult, but if I can tell you that it's less than 10 minutes to do it. I mean, the most important is the landmark. If you find the landmark, it's very easy because you have nothing to do. You have no implant. It just, I mean, the key point is to repair properly the landmark, which is the lateral epicondyle, the GERD, and the fibular head, but it's very easy. I would say that all the young friends or colleagues who want to do it, there is no difficulties. It's definitively less complicated than a Lemaire.
Okay. So, because we have many questions from the audience, I think it's the better time to have a mini break, and then all together, all the panel will answer the questions.
The powerful game-ready system provides optimal therapeutic benefits following injury or surgery. The dual-action wrap combines cryotherapy with intermittent compression. In combination, these therapeutic benefits reduce pain and swelling and help lower opioid use. To learn more about the GameReady system, visit us at gameready.com.
So we're back, and I hope in a minute we will all be together. Until then, if you're listening, and we don't have so much time, we have only 5 minutes. So my first question coming from the participants is to Mr. Iosifidis. Michali, if you hear us, can you please tell us what is the minimum bone tunnel length that you accept regarding to the length of your graft for your reconstructions?
Yeah, the minimum is less than 20. I mean, between 15 to 20. Let's say
so the less is 15.
15, yes.
15. Okay. Vasily, please go to the next
Robert,
speaker.
do you
Yeah.
have a clinical study comparing this technique, the previous traditional technique, and this technique is superior as concerning the clinical outcome?
We already started to compare it to the BTB graft. It seems to be better. You know, first of all, the patients come back earlier to the normal activity, and according to our study, according to the literature, 4 months after the surgery, they can start with sport. It's quite fast. But honestly, this study are already now in the process.
Okay.
Next question for Mr. Romain Sale from the participants. Can you please define what is a stable and what is an unstable rub lesion? Probably the participant would like to ask, do we have to repair all rub lesions or some of them can be left untreated?
Yeah, I know that there is some conflicting results in the literature. Personally, I repair all ramp lesions. The difference between a stable and an unstable one, well, you see it if you look at them. You have some very small lesions which do not move if you move the knee, and you have others you see right away from the start. If you have a big hole, or if you see the anti-posterior wall of the meniscus, you can go from the principle that it's an unstable one. And then if you look from posterior, as the videos I showed you, if you have this gapping between the RAM tissue and the posterior wall, that's an unstable lesion, and that needs to be fixed from posterior.
Okay, Vasily?
Romain, we know that mainly in the middle meniscus in the body, let's say, sometimes especially in young patients, in the meniscocapsular junction, we don't have to treat them, we're just doing the needling procession. Do you have experience with ramp lesions for this needling procession with the needle to promote the healing, or you just repair all the ramp lesions?
Yes, I don't have this experience. I think if you see a ramp lesion, and you saw that very nicely from the video I showed you when these lesions occurred, and the fantastic video that Bertrand has showed you, that they occur in subluxations of the knee. And I cannot imagine that by simply stitching a needle a couple of times in the lesion that you have a sufficient healing. And you need really to repair the tissue it's like a Bankert lesion. And you know that if you have a Bankert lesion, you do needling of the anterior labrum in the shoulder, it will not get back, and you will have what we call an Alpsa lesion. And it's the same for the ramps. If you don't bring the tissue back, they will not heal. That's my strong opinion.
Okay, thank you.
Mr. Hades, some surgeons do not feel comfortable creating a second femoral tunnel for for extra-articular tenodesis. Would you suggest that the staple is enough and safe enough and biomechanically strong fixation for the reconstruction?
I personally do not like the staple fixation, not even the anchor fixation. Definitely, biomechanically, the screw fixation is much better and superior. But the trick here is to, before passing your ACL graft, to put your K-wire for your lateral tenodesis femoral tunnel, and check at the same time arthroscopically if there is a coalition between your ACL femoral tunnel and your lateral tenodesis femoral tunnel. That's a very easy and safe way. And if there is no coalition, then you can proceed with your drilling, checking at the same time your tunnel. And if there is no problem, then you can be sure that there will be no coalition. And if sometimes you may have a coalition, but you can see it very easily with your scope, change the direction more anteriorly, and you can drill your lateral tenodesis femoral tunnel in a safe way.
And Bernard, we know that in the skeletal immature patients, in the children, there is a high retear rate. You point out that in your lecture. Will you perform in this population ALL reconstruction or modified Lemaire technique?
Hopefully, I mean, the failure rate for skeletal immature is disaster. There is already two series by Coker and by Wilson where they show that adding an ILL reduces significantly the graft rupture rate. So I'm doing a Macintosh with the IT band. So I mean, I use a very long strip of IT band. I leave attached to the GRD, and I pass over the top in the ACL. And we have a study coming with a low graft rupture rate around 4%, which is acceptable.
Okay.
Okay. It's now almost time to close our webinar. It's clear that we need to improve our results of ACL reconstructions. Today we've heard some very sound solutions, and I will ask the moderator Vasily, please give us the closing remarks. Thanks everybody for this nice webinar. Thank you.
I think that the main important thing is that there's no simple ACL reconstruction nowadays. We must point out the exact anatomy as Robert. We must see the concomitant lesions as Romain said. We must see the ALL, of course. We must improve our technique with new grafts, new technique, in order to have a better complication rate. So I think it's time to close this webinar. I would like to thank all the speakers, especially the speakers from Poland, from Luxembourg, and from France. I would like to thank all the participants, over 200 participants, and I would like a special thank to the Special Secretary of the Hellenic Arthroscopic Society for his contribution to this webinar. Keep in touch with the Hellenic Arthroscopic Society and with the ESCA, because in the future we have many webinars in all over the topic of the arthroscopic surgery. Thank you very much. Good night. Have a nice rest of the day all over the world.
Bye-bye.
Bye.
Have a nice day.
Bye-bye.
Bye-bye.
Bye.
The powerful game-ready system provides optimal therapeutic benefits following injury or surgery. The dual-action wrap combines cryotherapy with intermittent compression. In combination, these therapeutic benefits reduce pain and swelling and help lower opioid use. To learn more about the Game Ready system, visit us at gameready.com.